Good evening, ladies and gentlemen. We cordially welcome you to the International Technical Webinar on Advancements in Biotechnology, presented by the Department of Biotechnology from St. Joseph's College of Engineering. Glad to have a wide range of viewers for our initiative. Now, we enter into the session starting with Tamil Thai Varthu.
சீராரும் பதனமென திகழ்வரத கண்டமெனில் தென்கணம் அதிர்ச்சிறந்த திராவிடனை திருநாளும் தக்க சிறு திரையுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வழங்க இருந்த பெரும் தமிழகமே தமிழகமே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Now, I warmly welcome our organizer, Ms. G. Kalavati, Assistant Professor, Department of Biotechnology, to deliver her welcome speech.
Hello everyone. On behalf of the Department of Biotechnology, St. Joseph's College of Engineering, I take immense pleasure in welcoming the speaker of today's session, head of the department, my fellow staff members, participants including faculties, research scholars and students from various institutes across the country, and my dear students, to the Day 2 of International Technical Webinar on Advancements in Biotechnology. I'm sure that this webinar will give you some insights into the rescue stages of NASH and HCC. I once again am glad to welcome the speaker of today's session, Dr. Vijay P. Boominathan. You're welcome, sir. Now I request Ms. Sangeeta to introduce the speaker.
With no further delay, we welcome a star of the show, the speaker, Dr. Vijay Boominathan. Dr. Vijay Boominathan has completed his BTech Biotechnology in Anna University, and he went on further to pursue his Master of Science in Biotechnology in Claflin University. He attained his milestone by getting his PhD in Biomedical Engineering and Biotechnology in University of Massachusetts, Dartmouth. Dr. Vijay Boominathan has skills experienced in mammalian cell culture techniques, mouse handling techniques, blotting techniques, and statistics. Practice makes a man perfect. His working experiences are endless. He worked as research assistant in MS in Claflin University. He worked as doctoral research fellow assistant in Dr. Tracy Ferrari's lab in University of Massachusetts. Then as doctoral research fellow in University of Massachusetts, further as postdoctoral research fellow in Department of Medicine, University of Minnesota. Then as senior research associate in University of Massachusetts. Finally, he worked as postdoctoral fellow in Department of Surgery in University of Florida. He has done 23 technical presentations. Currently, he is a research scientist in Hepatobiliary and Transplantation Laboratory, Department of Surgery, College of Medicine, University of Florida. Today, he will be delivering information on NASH and HCC and overview to rescue. I request Dr. Vijay Boominathan to take over the session.
So let me introduce myself again, Vijay Boominathan. I'm working as a postdoctoral fellow under the mentorship of Dr. Ali Zampar, and I'm from the Department of Surgery, University of Florida, though. So today's topic, what I'm going to deal with is NASH and HCC, and overview to rescue, though. Okay, there it goes. All right. So I would like to thank the Department of Biotechnology from St. Joseph's College of Engineering for organizing this international technical webinar on advancements of biotechnology on this day. A very good morning, good afternoon, and good evening to everybody who's present around the whole world and who's listening to this webinar. To begin with, I would declare that I don't have any conflicts of interest to begin with. And to starting with the whole process though. So our lab at the University of Florida is pretty much working on liver and liver-associated diseases though. Our primary targets are ischemic reperfusion injury, which happens during transplantation, and HCC, hepatocellular carcinoma, and testing mice models though. I would not be talking most of my research work, but I'm pretty much going to give you the oversight of like what liver functions and liver diseases associated with NASH and hepatocellular carcinoma and how we could rescue it though. To begin with an overview, what is liver disease and what is NAFLD? I'll be going with all this like acronyms later during the presentation. NASH, HCC, where do we stand in terms of complications and rescue and current and the future treatments what are entitled with. So we know we all know that the liver pretty much is a primary organ of the body, and the functions are not limited to just like a breakdown and toxic like elimination. As the chart goes in, we could see the toxic elimination or the byproducts of medications are being taken down by the liver. And it is known for the bile production, the breakdown of fats, and absorptions of specific vitamins A, D, E, and K, processing of hemoglobin for use of its iron content, regulation of plasma proteins, blood clotting, and the clearance of bilirubin, pretty much the ones which is associated with jaundice. The immune factor control to fight bacteria, and the nutrient breakdown and the metabolism to supply energy from food. So moving from liver functions, what are liver disease? The deviation from normal function of the liver, that is the loss of functions, diseased or injured liver, is termed as hepatic diseases. It could be pathological. The most pathological conditions are the chronic inflammation, though acute is also there, but chronic is the most considered over here. NASH, cirrhosis, fibrosis, and HCC. The etiological agents which causes liver disease are primarily through infection, bacteria and other viruses, everything, alcohol, usage or abuse of alcohol, autoimmune disorders, metabolic syndromes, and drugs. NAFLD. What does NAFLD stands for? Non-alcoholic fatty liver disease. The term is also like being recoined as like a metabolic associated fatty liver disease in the future though, but yeah, let's go with the traditional one, NAFLD. The term was first coined in the early 1950s based on the fatty liver which was observed in obese patients. It includes a whole spectrum characterized by the accumulation of fats excessively who drink little or no alcohol itself. So this whole group of conditions could be characterized by the fat accumulation and inflammation. It begins with steatosis, the abnormal accumulation of lipids in hepatocytes that is not a consequence of excess alcohol consumption. And then it's characterized by the presence of sustained liver inflammation and the cellular damage happening to the hepatocytes. NASH can further progress to more chronic conditions such as a cirrhosis or hepatocellular carcinoma, starting from fibrosis. The chief causes, the lifestyle and dietary impact. Obesity and resistance to insulin plays a huge role in the progression of the disease. Pretty much like in 90% of the cases, people who are seen obese have these conditions. And also associated factors would be the presence of diabetes or a diabetes to condition. Disease progression and the mechanisms of this particular liver disease are not very well understood and had tremendous research models being involved in, like using mice, rats, and other animal models. Moving from NAFLD to NASH. Officially, the name NASH was coined by Ludwig and colleagues at the Mayo Clinic in 1980, which stands for non-alcoholic steatohepatitis. NASH is again a type of NAFLD, the non-alcoholic fatty liver disease, and is associated with liver cell damage along with fat accumulation with hepatitis. That's nothing but the swelling or the inflammation of the liver itself. NAFLD is observed in combination with the steatosis, starting from the benign liver cell injury and inflammation. And it further progresses to the end-stage liver disease, which is characterized by the cirrhosis or to primary liver cancers, which are irreversible at that point. Observed with a similar pathological findings to alcoholic liver disease. So pretty much what is the correlation between people who don't consume alcohol to an extent level or a significant level do also observe the same thing. And the presence is pretty much seen with the same as like what the pathology could be seen in alcoholic liver disease. The major cause of liver cirrhosis from scarring tissue otherwise is unknown and mostly observed in non-alcoholic diabetic patients, obese patients, primarily in women with no history of alcohol usage to begin with. But at this current era, everybody has it though. The mode of action, NASH technically takes like two different hits over here though. The traditional ones say like two-hit hypothesis. The very first hit is the steatosis or the lipid accumulation in hepatocytes, building up of insulin resistance, and the precursor for NASH routing to the second hit of pro-inflammatory cascade. The second hit usually involves the injury to hepatocytes, necrosis, inflammation, and fibrosis. The modern theory of like mode of action for the NASH is being split into is following the two-hit hypothesis to multi-hit hypothesis, where added factors, including the two-step hypothesis included, and other elements involving fatty acid, oxidative stress, the gut microbiome contribution in your body, and altered gene expression. The extent of hepatocyte injury from soft tissue to scar or hard tissue via oxidative stress and reactive oxygen nitrogen species ROS and RNS, and injury apoptosis and triggered pro-inflammatory cytokine action, altering the associated pathways contribute to this specific hepatic steatosis and inflammation, according to past source. Prevalence of NASH. Non-alcoholic steatic hepatitis, NASH, has been called as an epidemic, a ticking time bomb, and a silent tsunami. The progressive form of this non-alcoholic fatty liver disease affects more than 115 people worldwide. In the future, around 2030, it's estimated to be happening around like 357 million people, according to the Global Liver News. North America alone has an estimated NAFLD as one of the most common chronic liver condition, with 34% of the adult population at this point. 20% of the NAFLD categorized adults have NASH, according to almost 10 to 12% of the adult population. Though not worse, it always started with a simple fatty liver. In India, it's not the exclusion though. It lies between 16 to 30%, and in Europe, 20 to 30%, and China appears to be anywhere between 5 to 24%, according to Browning's group. The characteristic risk factors and interrelated clinical disorders common in every populations are diabetes, insulin resistance, glucose tolerance. Obviously, the whole world is not exclusion for diabetes at this point. And moving to that, obesity, particularly the visible fat in your body, hypertension and oxidative stress, hyperlipidemia or dyslipidemia in most of the cases. And in women, it's like characterized by polycystic ovary syndrome. Average age group was 35 to 55 years primarily, but latest discovery in patients in the recent time has revealed that adolescents and young adult groups, the categories as the AYA, around age 15 are also affected. Means the kids, even like the early teens though. Though observed primarily in women, now it's predominant in men. Obesity around the world. So this was a chart like which was built up in like early 2012, 2014 group though. And it was from the Lancet group where you could see the obesity in men starting up with the highest index in the North America, American population over here. And like pretty much like it's been scattered around there. Moving to the obesity in women, it's much more higher index compared to men though, because NASH was primarily seen as like a starting with women patients though, and then moved to the whole index though, BMI index though. So on a comparison on a left to right scale, you could pretty much see the intensity of like NASH progresses in terms of percentage, the 40 to 60% in the Northern America, and in women, it's primarily seen in the southern parts and other parts of Africa too, and the Middle East. Diagnosis: when a patient goes for NASH diagnosis in hospital, to begin with, the general medical history is what they see first, though. Overweight or obesity is the first primary factors. Insulin resistance in the body, elevated levels of triglycerides or abnormal levels of cholesterol in blood, and the metabolic syndrome, type 2 diabetes, alcohol usage on a daily basis. Though NASH is known as a non-alcoholic steatotic hepatitis, a significant level or like less than a significant level is considered as NASH, more than it considered as an alcoholic liver disease. Clinical: aminotransferases are the best biomarkers for liver injuries. Two major aminotransferases, ALTs and ASTs, corresponding for alanine aminotransferase and aspartate aminotransferase are the biomarkers which could be seen in the blood work though, and followed by liver biopsy, obviously, and it moves to the next case. Serological biomarkers, CH13L1 and HbA1c are also other serological blood markers what you could be doing a lab test to. Imaging techniques starting with ultrasound. Pretty much ultrasound, we know like how it works, like passing off your like a sound waves in your body and see like how the image gets built up. Computerized tomography, where pretty much like it's a combination of rotating X-rays, which takes multiple scan of your whole body itself. And MRI, again, another non-invasive imaging technology, which gives a 3D image of your whole body or organ you're concerned about though. Liver biopsy, the final one is like where you take a small, like you poke your body with like a small biopsy needle and just have the least amount of tissue what you get in though. At any points like where you see like a scarring has been forming, and the histopathological scoring has been like categorized and graded accordingly. The histopathology of NASH pretty much is the HCC liver, where it starts with steatosis though. Macrovesicular, which is nothing but the accumulation of fats and hepatocytes. Lobular inflammation is pretty much the mild to and frequent consist of mixed, acute, and chronic inflammatory cell infiltrates, which is pretty much your monocytes and neutrophils and mononuclear cells. And this presence of large number of neutrophils favors an alcoholic etiology, which is primarily a characteristic feature. Hepatocyte ballooning, degeneration, and necrosis. Perisinusoidal fibrosis. Fibrosis is very specific over here. It's observed as a factor called the chicken wire fibrosis. In the northern parts of America, the chicken wire fibrosis is pretty much the chicken coop, the presence of the wire in the chicken coop itself though. So pretty much this kind of fibrosis is observed in almost 60% of the patients, followed by lipogranulomas, which is a localized collection of inflammatory cells associated with fat droplets though. And then moving to fat cyst, mega mitochondria, where the mitochondria is pretty much enlarged in size, in particularly hepatocytes of concern. Moving from the pathological thing to like scoring, how the NASH scoring is being done. On the chart over the left side over here, from the group like Cohen, they have showed that the whole spectrum from normal liver to simple steatosis and NASH, and like from simple steatosis to NASH itself though. So this whole process is reversible. Moving from NASH to cirrhosis to hepatocellular carcinoma is kind of like a irreversible process where the liver could not be taken back to the normal form. Histological sections are shown over here. The portal triad is shown as a PT, and the central vein is shown as a CV over here, though. The normal architecture of the liver, H&E strain, all these are strained against H&E, is seen over here, where the pretty much the hepatocytes are very happy, like nice, having a tight network and everything, though. Moving from a normal liver to a liver which has steatosis, you could see the fat accumulation or the deposition of fat cells completely over here with all this white kind of ballooning structures though. It has a similar structure to NASH, pretty much where simple steatosis and NASH are interrelated, where you could see the whole factors over here. From NASH to cirrhosis, which is the irreversible step from there onwards, though, you could see the hepatocellular damage and the scarring tissue, what's happened over here. A good network of cells like hepatocytes have been seen over here, but apart from that, all the blue ones corresponding around are the scar tissue, which could not be the place where you could return back though. From cirrhosis, it moves to hepatocellular carcinoma, although the pathology is not being reported over here. What is HCC? HCC stands for hepatocellular carcinoma again. Fibrosis progresses to cirrhosis, where the soft, healthy tissue architecture of the liver is replaced by hard scar tissue within few years. It may take comparatively less time also. Cirrhosis to HCC progression is common in NAFLD and NASH. It's a primary form of liver cancer, as we know. Globally, HCC remains one of the most common cause of cancer-related death. The dysregulation of lipid metabolism and immune response plays a major role in the progression of the disease. Associated risk factors includes viral hepatitis B and C, the presence of alcohol, alpha-1 antitrypsin, and hemochromatosis. Alpha-1 antitrypsin is a glycoprotein which is largely found in the liver. It's a serine protease inhibitor. Dysregulation of this one disturbs the neutrophil balance in the liver, and it's known to contribute towards HCCs though. Hepatochromatosis is an inherited condition where the iron levels in the body slowly start to build up over many years. And this buildup of iron is known as the iron overload, which could cause unpleasant syndromes. And it's pretty much known to cause damages to the liver. Disease progression with diabetes has been observed with high prevalence in Asian countries with increasing rate. Western countries has shown that the development of HCC from NASH is similar to that observed from infection with Hep C virus in the case of HCC stop, according to Adams group. Here, pretty much we go with the pathophysiology of NASH and NASH HCC. The whole thing, the whole spectrum is shown over here from steatosis and lobular inflammation to NASH, where it moves changes and where the process could be reversible. And from mild fibrosis, partially reversible, to advanced fibrosis and cirrhosis. Now, a whole sequence of events happens over here. This lipidemia, where the accumulation of lipids or like a alteration or abnormal levels of lipids are being seen over here. Caused usually in the presence of high fructose or high glucose diet, sedentary lifestyle, fat tissue-derived free fatty acids, the presence of cholesterol, abnormal levels of cholesterol, the microbiomes, the gut-derived metabolic products, what's seen over there, and uric acid to begin with. So over the sequence of events, liver inflammation starts to happen. The presence of high elevated levels of CD8 plus cells, which plays a prime role in adaptive immunity and the release of T cell cytokines, though. Followed by CD8 cells, so cytotoxic T cells, and also plays a role in adaptive immunity. Activation of resident macrophages. Hepatic macrophages, they play a very central role in maintaining the homeostasis of the liver, as well as the initiation and progression of the liver disease. Hepatic macrophages are mainly derived from the resident hepatic macrophages. At these sites, they call the Kupffer cells, or circulating bone marrow-derived monocytes. And then they become inflamed or inflammatory macrophages. And also, like the next set of members called the TNFSF, tumor necrosis factor superfamily. And these molecules plays an important role in the activation, proliferation, differentiation, and migration of immune cells into the central nervous system. Followed by IL-beta, IL-6, and IL-17. IL-beta is again a potent pro-inflammatory cytokine molecule produced by the cells of the innate immune system and is known to regulate the macrophages. IL-17 is primarily observed in hepatic fibrosis, in particular alcohol-related though. And followed by PRRs. PRRs is nothing but the pattern recognition receptors, and these are expressed at the hepatocytes, initiating signaling cascades that trigger the release of factors, promoting the inflammatory response during NAFLD progression. Finally, we have the inflammasome. Pretty much they're also like cells, molecules which are being activated, and they affect the sinusoidal and the hepatocyte network over there. Moving from the NASH, the steatosis to NASH events, the events are driven by hepatocyte damage. Pretty much we have seen all the cellular factors associated with those ones. Endoplasmic reticular stress molecules, DNA damage happens over here, and oxidative stress also. From there, we move to mild fibrosis, to advanced fibrosis and cirrhosis, where it's irreversible, and to the final stage of HCC. Over here, through the sequence of events, we have chronic hepatocyte proliferation, chromosomal aberrations, chronic regeneration, activation of HCCs, activation of LSECs, and TGF beta, and increased IL-18 though. So what are hepatic HCC stands for hepatic stellate cells, which pretty much play a role in the lipid regeneration and fatty acid starting stellate cells though. Moving from that, LSECs are the liver sinusoidal endothelial cells, and they are highly specialized endothelial cells representing the interface between blood cells on the one side and the hepatocytes and hepatic stellate cells on the other side. These functions includes elimination of macromolecules and small particulates from the blood. They have an important role in the immunological side, interaction with tumor metastasis, and drivers for liver regeneration. IL-18, elevated IL-18 concentration and its correlation with hepatocellular injury has been always seen. It's known for systemic inflammation and degree of liver steatosis, and supports its role in NAFLD pathomechanism. IL-18 can also be considered as a role in predicting liver steatosis, and it's pretty much observed in obese children. And finally, the whole spectrum is seen over here with the increased risk with grade or stage of disease from steatosis to the final form HCC or the irreversible one though. So next one, so how we have spoken about the NASH, NASH moving into HCC, the final stage of primary liver cancer, hepatocellular carcinoma. How is it similar to the alcoholic liver disease HCC or the alcoholic liver disease driven hepatocellular carcinoma? A pathological features of tumor in patients undergoing orthotopic liver transplants with NASH HCC is compared against the ALD HCC though. This particular work was done by Zarimpar's group, and all we could see all the primary factors happening over here. To begin with, we have the first one chart with the NASH HCC, the non-alcoholic steatotic hepatitis, hepatocellular carcinoma, and the alcoholic liver disease, hepatocellular carcinoma. To begin with the tumor diameter, pretty much we could see there's not a big change over here, 2.95 to 2.93. Tumor numbers, we have almost like same numbers over here. The total tumor diameter to begin with 3.9 and 4.07, which is almost like same significance though. Multifocal, 13 out of 33 patients had it, and 20 out of 40 patients had it, contributing to 40% and 47% in total. Differentiation of the tumor, well differentiated 7 and 9, moderate 73% and 75%, poorly differentiated 3% and 5% in case of NASH HCC and the alcoholic liver disease HCC. Steatosis, the grading of like a histopathologic analysis where you could see like the fatty acid accumulation is 35 to 39%, 15 and 8%, 19% at 5%, and in a severe case, it's 31% to 47% though. We had finally the Mallory bodies. Mallory bodies are the cytoplasmic and eosinophilic inclusions in hepatocytes, and they're associated with the ballooning and the inflammation. And they're primarily found in the non-alcoholic fatty liver disease and hepatitis, hepatocellular carcinoma, and primary biliary cirrhosis. Global complications, where do we stand typically? The availability of organ is a major issue as a huge setback for organ donation. So moving from NASH and HCC, the primary things what we have is that like the immediate cure or the immediate rescue is going for organ transplantation. That's why we are considering about the demand for organ donation and the setback what we have the availability for organs though. Immunosuppression, rejection of the transplant organ followed by oncological risks. Long-term survival, typically 5 years in overall in 70% of the cases though. And wait list, not to be a limiting factor, is determined by multiple factors and also a challenge globally to prioritize at what age group, who gets it, like is the organ readily viable for everybody, and like among the waitlist persons, an organ can be available, but it could not be compatible with the person or the donor itself. Occurrence of NASH has been observed in most of the patients who underwent the surgical transplantation. That means the NASH is going to relapse after doing a surgical transplantation of the whole liver itself. The other important thing is lifestyle change failure though. Most of the people who has undergone the surgery and undergone like a liver transplantation and everything, they fail to accommodate with the lifestyle changes and results in the reoccurrence of HCC at a faster rate. Viral etiology and hepatitis C virus treatment also is known to bring back NASH HCC. So, what are current treatments happening for NASH? Technically, there's no medicines that has been approved for NAFLD or NASH. There are a few things which could be considered. For early NASH, presently the greatest effective treatment for NASH or NAFLD is weight management and body mass index control. Though assisted bariatric surgery for weight loss and all weight loss medications have been primarily being administered or taken as a procedure for treatment. Though lifestyle changes is a very significant thing. We need to emphasize the whole factor because this is the primary thing, which is the only one where the significant weight loss in the body could contribute to a way higher decrease in the NASH and HCC progression. Diet and exercise obviously is a cornerstone for future therapy, further therapy. Diabetes, insulin or hypoglycemic agents, primarily like pioglitazone, which is being seen over here. Surgeries, multiple mini invasive procedures, transplant or resection. Pharmacotherapy in the case of advanced cancers, sort of a classical treatment for HCC, a classical drug for the treatment of HCC. Kinase inhibitors including lenvatinib, regorafenib, cabozantinib, and assisted with supportive care. The current and future treatments, pretty much there are much more research being involved in developing and launching new techniques and new kinds of medication drugs to administer NASH and NASH driven HCC though. So pharmacotherapy can be effective in selective patients because each and every patient's individual and body conditions and homeostasis differ from one another. And according to Deha's group, pretty much the new emerging treatments are oncolytic virus therapies, immunotherapy, chemo and radiation together, targeting for the angiogenesis drugs like santinib, ravanib, linafenib, TSC68, and ramucirumab, everything though. Taurine, vitamin A, antioxidant glutathione treatments though. So vitamin E, why? Vitamin E is pretty much seen as a very powerful treatment in the case of NASH. It's an antioxidant and subsides oxidative stress, which happens in the whole NASH HCC events though. And antioxidant glutathione events are also pretty much contribute to the same thing. Anti-cytokines, anti-TNF, which is that human necrosis factor antibodies, and pentoxiflin, which acts as a primary weight loss aid, and it's known for changing the hepatic cells and improving the liver functions itself. Metformin, insulin sensitizers, pretty much with people with diabetes, is also seen as a primary one. Anti-lipid agents, simvastatin, pretty much is given for any patients with cholesterol and everything, and it's more common drug over there. Antibiotics and pre-probiotics are seen as to begin with early lifestyle changes itself. The future treatments. So the whole liver picture is seen over here and seen what all targets could be seen could be targeted over here. To begin with, we have the ASK1 inhibitors, apoptosis signal regulating kinase, which reduces apoptosis and oxidative stress, and which is seen over here. And ACC inhibitors, the acetyl-CoA carboxylase, which is a very complex and multifunctional enzyme system which catalyzes the carboxylation of acetyl-CoA to malonyl-CoA, the rate-limiting step in fatty acid synthesis. And we do have some mitochondrial inhibitors, lipogenesis, PPAR agents, peroxisome proliferator activator receptors, GAL3, which is markedly upregulated in liver disease and has effects on the main two different types of cells involved in fibrogenesis, both the macrophages and the stellate cells. Apart from that, we have FGF21, TNF alpha, anti-factors, aramcol, and everything though. So all this one has a specific target over here, which could be seen, and those targets are focused to make a potential therapeutic drug itself though. Begin with insulin-resistant modifiers, PPAR and GLP-1, the necroinflammation and apoptosis markers for stress, including GFG21 and vitamin E. As I mentioned, it's a huge role in antioxidation. Inflammation markers, ASK1 inhibitor and FGF21 again, and tissue fibrogenic remodeling, GAL3 known as for tissue remodeling for the fibrogenesis, macrophages, and stellate cells to begin with. Clinical trials, lipogenesis target aramcol has been a big thing going on though. Kinase inhibitor for apoptosis, saloncelcrib, GAL3 protein inhibitor, GAL3 protein inhibitor for antifibrogenesis, GRMDO2, elevated triglyceride treatment, saroglitazar. To conclude the whole thing, so where do we stand? What's the take-home message though? In the long run, huge selection of cellular and molecular events concerned with NASH has become like potential targets to subset both NASH HCC progression. The future treatment has set novel path for many altered approaches, breaking the traditional stereotype ways of treatment, and are mostly under clinical trials at this point though. Lifestyle changes and improving the quality of life shall be the greatest benefit to halt the precursor events, diabetes, cardiovascular disease, insulin resistance, and dyslipidemia. So all these becomes as the associated factors which could be contributing to the start of the simple fatty liver or the steatosis as a key sign itself. With that, I would like to finish our presentation. I'd like to thank Dr. Ari Zainpa, who is my PI, and my colleagues, Sergio, Atsushi, Dr. Serena, and Curtis, though. And at this point, I would be most happy to take up any questions, though. Thank you, guys.
Thank you, sir, for an educational and informative session on obesity and its relationship with NASH and hepatocellular cancer, as well as providing possible future treatments for it. We have a couple of questions here, so shall we get into it?
Sure, please go ahead.
Yes, sir, I'll read them out to you. So the first question is, what is the pathophysiology that mimics experimental HCC and NASH ALD when compared with human?
The pathophysiology of NASH and HCC.
Yes, and ALD when compared with human.
So all this data are pretty much the human ones. So these are not from the mice or any other research models, what I have shown over here. So let me go back here. So in the case of NASH to cirrhosis, NASH pretty much you see a high fat accumulation over here. But moving from NASH to cirrhosis or hepatocellular carcinoma, which is like shown over here as the whole liver, not the pathophysiology though, a higher number of scarring tissues being seen. The more number of scarring is known to increase your blood alanine transferase level, ALTs and aminotransferase, which is going to be your liver bioengineering markers though. Elevated levels of those ones are produced by the injured cells of liver, the scar tissue. And this would be a characteristic feature of like NASH to HCC itself.
Okay, so thank you, sir. The next question is, why do North Americans hold the highest number in obese? And is it because of their food habits and their lifestyles, or is it due to geographical reasons?
Yeah, there could be multiple factors involved though. So I'm not going to be very stringent about saying the fact like dietary conditions would play a higher role though. Dietary and sedentary lifestyle could be a higher role. Apart from that, the geological data mining and like amount of data what could be observed over here could also be a higher contributing factor though. So this particular obesity chart which we have seen over here was in the early 2012 or 2014, I believe though. Okay, let me go back to the narrative. Yeah, this this work was published in 2016. So the early 2012 to 2014 is where the data is shown over here with the obese characteristic feature though. And as I mentioned to begin with, the prevalence of NASH is almost like subsiding. It's not subsiding. It's being increasing in every country. India, it lies 16 to 32%. Europe has moved to 20 to 30%. And China appears to 5 to 24%. It's like 25 to 24% is a big range, but yeah, going for the upper index of most countries, everywhere it's more than 25% to 30% though. Whereas in the case of like Northern America, we pretty much see 34%, which is almost mimicking the whole thing around globally. 34% in North America and yeah, 32% highest in incidence in India, 30% highest incidence in Europe, and 24% highest in China though. So the availability of data could be one important factor also, which could be taken into consideration. So I'm not going to be, not going to say like sedentary lifestyle could be a factor though, but I'm not going to spell it out though.
Okay, sir. Thank you, sir. The next question is, why isn't many immunotherapy not successful for HCC when compared to chemotherapy?
So immune suppression drugs act in a wide range of mechanisms. So the pathways which control are still being considered. And moreover, this like in NASH HCC is pretty much starts with steatosis or the fat accumulation. Lipidogenesis is one another factor which is contributing compared to other chemo or other types of cancer or other chemo treatments though. Most of the chemo treatments, they don't have multiple factors, like they do have multiple factors, but in liver, they have more added factors to target though. And you move to the whole liver chart, what we see over here. So if you do see, yeah, there are like multiple factors, like multiple like pathways. This is like just a few pathways which is shown over here. Apart from that, like immune cell trafficking, regulatory cells, or the anti-inflammatory is pretty much only one part of the immunosuppression drugs or immunocompetent drugs which are in the process of developing though. Chemo would address most of the factors in terms of like apoptosis, necrosis, and like killing of cells. So, and in liver, pretty much like cirrhosis or fibrosis has already taken down a part of the liver cells, a viable liver cells itself though. So targeting more over that would become a challenge at this point. And the specific pathway targeting or inhibitor targeting is one prime factor though. So that's where each and every company or each and every research group has been working on one specific molecule, the PPRs, insulin sensitizers, ASKs or ACCs, or yeah, those like focus is very small at this point though. It's not a widely spoken fact that chemo is advanced one compared to immuno one. Both each and everything has its own setbacks and pros and cons though.
Thank you, sir. The next question is, our country, I'm guessing they mean India, has different food habits with different food combinations. So which food components are cause hepatocarcinoma?
I'm on a dietary perspective here, I'm not a very big fan or a very big person who can advise you on that one though. But in general, the first change what they had made over is like to move from very high intake of food to go for portion control to begin with. Most of the things what they mentioned is like a reduced calorie intake or a high protein intake, low carb intake, or like a high protein and low fat though. So pretty much you have like your amount of like food what enters your body, which is going to be high carbs or like moving into like a fat deposit into your body, should be not eliminated. I would say should be like controlled vividly than your previous food habits though. So high carb would definitely high carb with like no exercise and no physical activity would definitely going to be like I say free food storage in the body, and it's going to be like increasing your visceral fat around your whole body itself though. So a high protein diet would be doing good, and portion control is one chief important thing which could be seen to at least change your lifestyle to begin with though.
Thank you, sir. The next question is it possible to find the metabolomics of liver metabolism related diseases using computational biology?
Oh yeah, like there have been tons of works being done over there though. So like a few of our collaborators and groups like which I'm involved in also, like we are studying about the metabolomics and the transcriptomics which are concerned with the whole development and pathway of this one though. And there are a few works done by like experts in the field, like where they have shown starting from every factors, the microbiome metabolomics, the like transcriptomics and metabolics, which is concerned with the liver and with the normal liver and the liver which is developing to NASH, to HCC, NASH to fibrosis, to cirrhosis and HCC also. So the fact is like how do we combine all these factors and put together? And each and every group has their own starting place to begin with, and they have their own corresponding findings though. Yeah, that would definitely say like computerized techniques are being available, and metabolomics are like one key factor to start the whole question itself. What your question is going to be a driving factor.
Okay, sir. The next question is there any nutrition restriction required for treating hepatocarcinoma?
Not sure though, because like hepatocellular HCC is a vivid term. NASH HCC is different, alcoholic liver disease HCC is different, and viral induced HCC is different though. So I'm not sure. I mean, like I never worked on the nutritional part or the dietary component of this particular HCC though. But yeah, maybe it could be involved though, because like, at least for the NASH model, if you consider alcohol or the significant amount of alcohol intake associated with like fried foods and high elevated fatty foods, yeah, it should definitely play a role for sure.
Okay, sir. And the last question for today is how fast stem cells could be replaced for organ transplant?
stem cell therapy for organ transplants. Yeah, there are works going on though. Like few other groups who I do know, they do work on liver on chips, and they have started from one stem cell progressor to move to like differentiating to multiple different cells though. The cascade of life with stem cells is the fact that how do you maintain the organ architecture, and how does the organ maintain its metabolic functions also. Those are the biggest challenges at this point. Biomaterial, a person who is working on biomaterials and organ designing at the 3D level could be a better person to respond to this question though. But yeah, works have been pertaining over there. Liver on chip has been a liver on chip compared to over the lab on chip a proposed idea came up, has been the works are going on though, pertaining though, and showing positive signs for future transplantation.
Thank you, sir. And actually, we have one more question, sir.
Sure.
Yeah. So, how does probiotic affect our liver, and can it ever be replaced over conventional liver therapies?
No, it could not be replaced though, for sure with the conventional liver therapy. It's one of the things which could decrease or reduce your inflammation to begin with. And yeah, probiotics, the way it how does probiotics play a role over here? The microbiome for sure, where metabolic microbiomes which is responsible for your gut bacteria could play a role over here though. The amount of presence and increased amount of specific bacteria or bacteria which could be known for your lactic acid, acetylysis, or the procession could be factors. So I'm not sure. Yeah, it could not replace liver therapy for sure. It could be an additive or associated added benefit though.
Okay, so thank you, sir. We are done with the Q&A session with that. I thank you once again for taking your time to answer all of the questions, sir.
Thank you for the group though, and I apologize just in case if I did speak faster because I'm known for that. But yeah, apart from that, I hope it was an educational seminar and it was good for you guys though. Thanks again.
I now request Dr. LFA Anandraj sir, Associate Professor, Department of Biotechnology, St. Joseph's College of Engineering, to deliver the vote of thanks.
Good evening, everyone. It is my pleasure to have the opportunity to give the vote of thanks on this special day. Showing gratitude is one of the simplest yet most powerful things human can do for each other. On the behalf of Department of Biotechnology, I express my sincere gratitude to our Honorable Chairman, Dr. B. Boominathan sir, our Managing Director, Mrs. S. Jessipriya ma'am, our Director, Mr. B. Sasishekhar sir, for giving the opportunity to conduct this international technical webinar on advancement in biotechnology. I would like to express our deep gratitude to our beloved principal, Dr. Vaddi Sheshagiri Rao sir, our Dean, Dr. B. Parvavadini ma'am, for providing continuous moral support, encouragement, and guidance. I also wish to express my gratitude to our HOD, Dr. G. Srikumar sir, for his minute-to-minute guidance and support, and for providing encouragement at every point of time in organizing this great event. I extended my special thanks to our guest speaker, Dr. Vijay Boominathan, research scientist from College of Medicine, University of Florida, for accepting our invitation and sparing his valuable time with us. I want to appreciate our speaker for making excellent presentation and making this webinar interesting and meaningful. His presentation clearly reflects its in-depth knowledge in the field of liver diseases, and this will surely encourage us to explore further research in this area. During our earlier discussion, our guest speaker is very kind enough to attend our meeting without bothering about the timings. He has given his fullest cooperation to make this webinar a successful event. Thank you very much for enlightening our minds in this new area. In organizing any function and making it a success, there are always some silent workers who prefer to remain at the background, but take the major burden on their shoulders. I want to thank my co-organizers and our third year biotech students who worked behind the scene to make this event happen. I also thank all the participants for the patient listening and for maintaining the decorum throughout this meeting. Last but not least, I thank Almighty for gracing the successful completion of this occasion. Thank you once again. Bye.